Live from the SABC's Auckland Park studios, welcome to this week's second edition of The Watchdog. My name is Vuyo Mvogo, and here's what we have in store for you this evening.
They do need to appoint, I think, people in leadership that are competent at almost all levels. I mean, the HR system there, it's not, I think, consistent.
Health Ombud describes some of the most horrendous experiences pregnant mothers and children were subjected to at a Johannesburg public hospital. We bring you some of the terrifying things that Professor Malekapuru Makgoba said today before our panel for this evening looks at some of the experiences that professionals on the ground have also observed in other public hospitals across the country. And President Cyril Ramaphosa and his working group on disability meet again. But is any meaningful progress being made to address the core agenda of South Africans living with disabilities? We speak to one of the people who attended that high-level meeting. The Watchdog starts now. Pregnant women sleeping on the floor, hospital personnel raped on the hospital's premises, staff cars stolen. Only some of the revelations Health Ombud Professor Malekapuru Makgoba made today after handing over to the Health Minister a report of his investigations into Rahima Musa Mother and Child Hospital in Gauteng.
The allegation that the dignity of the patient was not being respected becomes really obvious. If you have a pregnant woman sleeping on the floor, you obviously take her dignity. If you have pregnant ladies that are in a hospital that is unsafe, where the toilets are not functioning, the heating system cannot function because of the breakages of the system, that cannot be a dignified environment to find yourself in.
Well, joining me now for a conversation not only on the Rahima Musa report, but also to talk about the experiences of professionals on the ground, what they continue to see and observe and experience in other public hospitals across the country. Please welcome Dr. Josi Letlape, who's a healthcare activist. Sibongile Chabalala is the Treatment Action Campaign chairperson, and Russell Rensberg is a Rural Health Advocacy Project Program Manager. Good evening to all of you. Thanks very much for agreeing to come on.
Good evening, Vuyo, and the comrades.
Thank you so much. If I may start with you, Songel, I mean, your organization has, over the past couple of years, been writing reports about experiences, of people who go to public hospitals, whether it's for, antiretroviral drugs, whether it's for treatment for TB and so on. Now, listening to this, and of course all this coming also, on the back of the whole Life as Esidimeni saga, what went through your mind as you listened to or read what Professor Makgoba had to say today?
Honestly, Vuyo, I wasn't surprised. I wasn't surprised of the findings, because these are the very same findings that we find in 2021 when we were doing our hospital monitoring in Gauteng, and that led us to sleep in the cold 2 nights at the offices of the Premier of Gauteng, then David Makura. And what all the things that are coming up in this report, these are the things we've been complaining about. These are the things that we've been identifying in our public healthcare system. You know, women sleeping on the floor, that is not an issue of Charlotte Macleay or of Rahima Musa only, but it's open, it's happening in almost every hospital around the country, especially in Gauteng. I can tell you about what is happening in Sebokeng Hospital, where there are a lot of cases of obstructive violence that are happening there, at Charlotte Macleay, at Telemogorane, actually all the hospitals around Gauteng. I can confirm that that is a situation. If you remember, Vuyo, we also raised a similar case in Tembisa Hospital a few years ago before we had COVID-19. I think, if I'm not mistaken, around 2018, where we're raising same concerns of women sleeping on the floor, and others, they were giving birth on the floor, others, they've lost their children. So the issue of the healthcare system, it's a long-standing crisis, but now, because the health ombudsman it's involved, maybe we will see some improvement in terms of the political will. But so far, I'm not surprised, because all the things that have been written there, we've been talking about them, but unfortunately, nobody listened to us.
Very surprised, Russell?
Yeah, I think I wasn't surprised. You know, I think we've been in a state of decline in our health system for at least the last 12 years, right? I think sometimes well-intentioned policies ended up crowding out the things that we needed to do. And I think I'm more shocked that even with COVID being the kind of pandemic that affected everyone, when we look at the data around COVID, we had a very unequal response, despite everything that the government spent and invested in. And I think for me, this should be a turning point in our system, where we actually stop and draw a line and figure out what is the kind of health system we need, right? And what is the one that we can actually deliver. And really start looking at ways and means that we can optimize our collective effort and start seeing an improvement. Let's not 5 years from now also reflect back on the Rahima Musa report, and rather see this as a touchstone to start building a more equitable healthcare system, because there are pockets of excellence. Right? I don't think that this is a position in every single hospital around the country. I think there are some rural hospitals where if I still had if we were still of childbearing age, we would deliver our baby there. But then there are also other places where I wouldn't let anybody go to. Right? And I think it's really just a matter of us stop just oiling the wheel that makes the most noise and start talking about how do we fix the system. Right? Because I don't think we can have another decade of talking about a failing health system and not doing anything.
Doc, Russell talks about drawing the line, fixing the systems. Bongile was talking about political will. One of the ironies of this whole episode is that the people who blew the whistle or who exposed this were the first to be hounded out, instead of a focus on actually fixing the problem, or displaying the political will to actually address the issues, instead of hounding out people who were concerned and who made their voices heard.
I think it's a mistake to keep talking about political will. We need to go back to basics, where all of us have lost our humanity, and that's where the problem lies. I was sad to hear the ombud say that he wouldn't let any of his relatives go to that hospital, but he would only go there if he was unconscious. And I asked myself, we have a 6-week-old grandson in the family that was born there. So the things that I have on the report, I've seen myself. And I ask myself, what type of grandfather am I to let my nephew and his new wife have their child there? And all I can say is that our ancestors have not forsaken us. And that's why we have a grandson. And that's a sad, sad state of affairs for this nation. And the key issue is the fact that we have two South Africas. And we can sit here and lament. My children were born in a private hospital. My first daughter's daughter was born in a public hospital. I would hope that I have the resources for other grandchildren that come along. But we can't be in that situation. And it is the separateness that is at the root cause of these problems. And that is why we are indifferent. Public health care has been underfunded for all these times. If you look, we have millions of people who could have died if they were not an ARVs. We had to fight. We had to take the government to court. Zaki Ahmad had to sacrifice, not take ARVs, be on death's doorstep. We had to march. I led a march of doctors without compromising patient care. Courts had to order the government to provide mother-to-child transmission. The stone deafness of privileged South Africans. So unfortunately, what our health system shows us is that apartheid is not dead. It's just administered by black people that have been admitted to the white world. And the white world that used to be a fantastic public healthcare system that performed the first heart transplant in the world has progressively, systematically become privatized through an act of parliament called the Medical Schemes Act. So me and you, we're privileged to have joined whites in what is now called private healthcare. We have not been committed as a nation. There's no nationhood in this country. We couldn't even change the name of the country for the new dispensation. We're still the Republic of South Africa as Verwoerd left it. That's the reality. We have embraced apartheid. We administer it. And we come here and shed crocodile tears like we care about what happens in those hospitals. All we aspire for is, as the ombud put it, none of my relatives will go there, and I will not go there. And until the head of state has his care there, until Vuyo and Khosi Letlape have their care there, this will never stop. This will continue, and we'll come up with band-aids and come here and pretend like we care. We just self-centered and we don't care about the lowly. And we've just redefined apartheid. It didn't die. We were taken in for a ride. We had hoped that there would be a new dispensation. But we've lost our humaneness, particularly those of us who've been oppressed. We've embraced whiteness and we've abandoned even our own relatives.
Songile, you know, Professor Makgoba talks about when he was talking about the CEO of the hospital, who, I mean, more than 2 months of a stay there could not be accounted for. But then later on, he went on to talk about how this is a situation everywhere. He mentioned the number of public hospitals, your Steve Biko's, your Charlotte Maxeke's, and so on. But also was talking about first how when these people are recruited, the rules are not adhered to. The performance criteria, the criteria that is set for the appointment of these CEOs is often overlooked. A suggestion there that often politicians lean on those who form part of these panels that appoint these people, and he reckons that is where it starts. For example, I mean, he was quite, you know, straightforward about how he felt that the CEO at Rahima Musa should never have been there or qualified, even though he had empathy, I mean, for her and the situation that she found herself in and how she should be supported. But one could deduce from what he was saying that that person should never have been there in the first place. And I was saying, I mean, in several other conversations the ombud was having afterwards, says this is the case across Gauteng, where you have people being suspended or people having to be fired, you know, precisely because they're not supposed to be in the positions that they would have ended up occupying.
Yeah, it goes back every year to the issue of political will. You know, I will emphasize this part of political will, because whatever that is happening, as Doctor said, that this is an issue of apartheid, the way we are living it comes back to the issues of politics. The healthcare system, it's been politicized in such a way that they are overlooking what is very important. We have incompetent people who are given positions to manage hospitals because of political guidance. Some people who are sitting in this panel are not, as much as they might see that Sibongile is not competent, but because there is a political instruction from somewhere, they have to place Sibongile in that position. We know of a lot of stories where people were given positions in the healthcare system, but they were unable to resume their work. They are unable to do what they are supposed to do. And coming back to the issue of the CEO of Rahima Musa, and unfortunately, the attitude she had, it's very disturbing. I remember in 2021 when we went to monitor that hospital to look what is happening, and she was not in the hospital. None of the management knew where she was, and when she was called, she told us straight to say, what do we want in her hospital? Why we didn't have permission from her? I had to take on to say, this is not about you, Sisi. This is about people's lives. This is about people's lives in danger. What is happening at Charlotte Makwege? We're about to see it at Rahima Musa, and you come here and tell us about your authority or why you are not at work. None of your management know where you are, and you come and ask us to say why we came to the hospital. The next day when we met her, she came back and tell us that we called her, she was in the funeral. If she had a funeral, why not all her management didn't know that she had a funeral in her family? And she had to report that she has to follow all the processes. And when I was reading the report, where I saw that she took more days, it showed that what she was doing, she was not always at work because she didn't have a plan. She didn't know how to execute her responsibilities. That is why you find that hospital in that situation. So we need politicians who will put their foot down and say, this is the kind of healthcare system that we need. And you are right, Doctor, to say people, as Prof. Mahoba said, that they wouldn't subject any of their family members to go to public hospital. It's because public healthcare users, they don't, workers, I mean to say, they don't use those hospitals. As there was a strike last week, some of the healthcare workers, they were hospitalized in private healthcare sectors while they are supporting the toy outside. So who suffers most here are the people who are on the ground, are poor people who cannot who cannot afford a private healthcare sector. All the departments, all the government officials, all the government ministers, they have medical aids. That is why they don't care about what is happening. If they had a political will, some of them, they will not go to the public sector because they had TB or they have to collect their high blood treatment because they know it's the best, but they will use it fully for them and their families. So we need politicians that will understand what we are going through as communities so that they can feel the pain, so that they can have a political will and they can be able to take steps that will favor communities at the end of the day.
And it would seem, Russell, it was true for the chaos that was described around the CEO and management of the hospital. It was also true for senior, middle, and lower management. I don't know if we can play a clip from the ombud talking about these trust agreements between supervisors and supervisees, and so on.
The leadership issues at Rahima Musa, that they do need to appoint, I think, people in leadership that are competent at almost all levels. I mean, the HR system there, it's not, I think, consistent with the level at which the hospital is functioning. And also, I think we have recommended that they should go back to the 2016 report and look at it when they are doing these recommendations and sort it out. They should look at their staff establishment, particularly their nursing establishment, and they should try and establish an ICU.
Looks like it's barely functioning.
Well, I'm a pragmatist and an optimist, right? I think it's really hard. And I think one of the things that haunts me is, you know, do we really generate confidence in our public health system when we're constantly picking away at what's broken and not looking at how we can fix it, right? So in the first instance, 360,000 people died from COVID. Only 106,000 had an official diagnosis, right? Just the rough estimate suggests that close to 200,000 people died at home, right? Maybe they didn't want to even go to the hospital. Maybe they saw all these television reports or senses and never interacted with the health system, or the health system is something that's foreign to them, and they died at home. There's nothing more undignified than that. And really, and I think it should be a turning point for us. You know, if we know for a long time that management and leadership is a problem in hospitals, we haven't done anything to address it. We have a very poor governance framework that oversees hospitals, you know, because those CEOs act alone. You know, there's no oversight, there's nothing there. And there's no independent measures as well to say, okay, this is how we measure, this is a good hospital, this is a bad hospital. But the bottom line is that we have 600 of these hospitals across the country. We have 3,500 clinics, right? We have what I call sometimes a National Health Service light, right? The National Health Service in the United Kingdom spends close to 3 trillion rand a year to keep their system going. We run our system on a fraction of that, right? 240 billion, I think that's less than like 2% or 5%, 10% probably at best. My math is not so great. And I think one of the things that we need to do is that we need to take a step back and figure out what is the system that we can afford, right? South Africa spends way more than what we should relative to our health outcomes. 60% of our healthcare spending on hospitals. Healthcare costs continue to rise. You know, in 2010 we introduced occupation-specific dispensation to
But
increase.
are we getting bang for our buck?
No, we're not. This is the point that I'm trying to make. How do we move out of this when the only thing that we respond to are when the wheel is making the most noise? And we haven't really had a chance to look at this whole thing systemically. When we look at the most basic health data, right? So access to maternal and child health, including sexual and reproductive health. In some places we're doing really well, but when you move out of the cities, we do considerably poorer and poorer because health follows the social gradient. Poor people don't access the health care they need when they need it. But all our investment is for a small percentage of the population that's relatively not in hospitals that aren't very accountable. Right? We don't know what happens in them. Outside of the Western Cape, few hospitals can tell us that these are the amount of patients that we've seen. This is the kind of ailments that these people had. This is how we're making sure that we're expanding access on cancer care. Right? We should actually be looking at, and a lot of people get cancer, right? You often only get it at the last stage of the disease, you end up in the hospital. But what are we doing to prevent it? And in our health information systems that should be informing governance, actually telling us that out in Limpopo, we're seeing a rise in cancer diagnosis. Are we only seeing people at the end of their lives when we're literally just giving them palliative care? Our country is a country with a weird demographic. We have lots of young people and children and lots of old people that have lived longer. We've got 6 million people on HIV treatment today, or 5.5 depending on who you ask. But they're surviving HIV, but they're dying from diabetes and hypertension. Right? So I think as much as it pains me what we heard today, this is not a new story. Right? And I do think that we have some of the smartest healthcare workers, some of the really good administrators in the system. And really, we need to move away from like a health compact. We actually need to sit down and figure out how do we fix our broken health system. Right? So in Gauteng, we know there's a problem. In the Western Cape, we know things work maybe a little bit better. They manage their care a little bit better. But they also have a different population demographic. In the Eastern Cape, things are near collapse. In Mpumalanga, things are terrible. In Limpopo, things are terrible. In KZN, things are declining. And I think to fix this health crisis, we really have to look at it and say, how do we improve primary health care in the first instance? Maternal and child health, infectious diseases, non-communicable diseases. How do we prevent them? How do we do well at addressing some of the social determinants? Then with our hospitals, because we invest so much money in them, Let's invest in the systems to tell us what we're doing, right? And the measurements to make sure, because we don't have those at the moment.
So it is about leadership. And probably, I'm not saying money is not a big part of it.
No, it's leadership.
But it is
about making the hard choices.
And Doc, this is what came to mind earlier when the Health Minister, Dr. Joe Pahla, in his response to after he was handed over the report by the ombud, he said in part that they would engage with the provincial government departments to secure the necessary funding to allocate for the infrastructure refurbishment of the hospital and to work to perform human resource and procurement policies to allow for agility in responses to immediate challenges. The point about this is that these are all the things that the ombud found, and these are not things that need money. These are things that there is money for, but the people are not performing, in their task. And here he is saying he's going to throw money. It's going to,
I think there's R1 billion in infrastructure funding.
I think there are fundamental problems. We speak about COVID. The Prime Minister of the UK nearly died from COVID, Boris Johnson. He was treated in the public healthcare system in the UK, the NHS. He didn't go to a different facility. He wasn't taken to private. He wasn't taken to Bond Street. That is what is required. Now, I'm not saying the officers that are appointed to the hospitals do have the necessary skills, but we should stop using them as scapegoats. Because you see,
or if they can perform,
if you are put as a captain on a sinking ship, a good captain is not going to keep the passengers on the ship. A good captain will send out an SOS and will try and save as many people by shipping them out. When we talk about pregnant women on floors, did that CEO have the authority to say, our capacity is so many beds, we full? Premier, let's divert to the empty private sector labor wards. Because that's what should happen. She's expected to cope with the floor beds. We've had floor beds at Bara. Because our lives are not as worthy as the lives of others. I work in a private hospital. When they are full, they close up. They divert to other hospitals. They don't take floor beds. They divert. That's good quality care. When you come to public hospitals, you can't do that. It's only when there's an emergency like right now and people are saying, let's transfer to the private sector. In Rahima Musa, there have been floor beds for pregnant women. Nobody talks about, let's transfer to the private sector. That CEO must see what they can do with that situation. That is not a fair playing ground. What we need is solidarity. I think, this lemon that we have in healthcare, we need to fix. And that is a pathway to a new South Africa. That would be a new name. What poor people need is solidarity, not charity.
But they need care.
When you build a health system, it has to be based on solidarity. It has to be for all of us. People talk about there's no political will. It's not about political will. It's about a well-developed sense of self-hate from nearly 400 years of being dehumanized. So our dream is not restoration of our humanity. Our dream is being white wannabes, whether it's in lifestyle, whether it's in residence, whether it's in faith. We want what is white. So what drives the issues in South Africa is not lack of political will. It's self-hate. We want to be where the whites live. We're going to the white hospitals. We're not building our own. We take our children to white schools. We're not rebuilding the schools that we come from. We've abandoned them. And we treat them as archaic. That's because we hate ourselves.
With respect.
We hate ourselves. And until we deal with it, until we say, even a poor African, even a poor colored, even a poor Indian is human. Even a poor white is human. The fault lines have become being poor, no longer the issue of color. And it is far, far more detrimental to people's health than before. So if you do not resource these hospitals, if you do not give them authority to be able to fix a broken toilet, it's got to go through public service. You go through an onerous administration system. Whilst the toilet leaks, and you as the CEO become a scapegoat, you got no authority to look for a local plumber in Westbury to come and fix that.
And therein lies the solution. You know, I think at the end of the day, we have a very tortured history, right? And I think that history is still with us in many ways, because inequality is still racialized. But let's come back to Dr. Letlapie's point here. It's about devolution of authority, right? It's about giving hospitals their own budgets that they govern themselves, as allowing them to set their own priorities, and for them to design the care system that is best appreciative to the communities that they serve. In a 5-kilometer radius, we have Charlotte Matreka, we have Helen Joseph, we have Rahima Musa, and we have the Nelson Mandela Children's Hospital, which is a quasi-private hospital, which is half empty, right? And we have to start asking ourselves, do the facilities that we have, are they still fit for purpose, right? Does it make value for money to keep Rahima Musa open, right? Or is it better to invest in expanding what care is available at Nelson Mandela Children's Hospital, which is a brand new facility, which is not funded by the state, but was intended to be funded by the state? Would it be better to take all of the capacity at Helen Joseph and concentrate it at Charlotte Matreka? It's still within 5 kilometers of the people that it serves. We can expand care and we can give quality health care. But to do that, we need to start using the tools that we have.
But
right?
you see,
and we need to start giving the authority.
I think we need to be, but we can't talk about that.
We can't talk about race.
Mill Park Hospital. He's excluded the rehab center that's just 500 meters away. We exclude Rosebank Clinic. You exclude Brentest. Until those are part of what we talk about.
But then nothing's
for all
happen,
South
Dr.
Africans. No, that's where
right?
you need political leadership.
Poor people on the ground.
You need political leadership. We don't need to ban our country to get it to work.
That I'm talking about. Where I'm living, there is Telemukorane, and just next 2 kilometers down the road is Butsilong Hospital, which is a private sector. People are going to Telemukorane because they don't have a way of going to Butsilong Hospital. So here, what we need to talk to is the public-private partnership that it's been on paper, but it's not implemented on the ground. When are we going to push for that to happen? When are we going to? Our government made these laws that are in paper be implemented on the ground to say if the Telemukorane Hospital is full and they don't have capacity, they need to transfer people just near the corner at Butsilong Hospital. So what we are talking about, it's a theory, it's what needs to be happened. But now the situation that we are in, poor people are suffering mostly because of what is happening in the country. Everything that is happening, we can count race, we can talk about everything. Poverty is poverty, it doesn't have a race.
Absolutely.
Poorness is poorness, it doesn't have a race. But what we need is our right as poor people to be respected. We need a right to life, we need a quality healthcare services, and until we have people who are in power, who are willing to give us that, unfortunately, whether we have a scapegoat to say we can't blame the CEO, we can't blame who. If we give the money, the budget to the CEO, but if the CEO is incompetent, that money will be rechanneled to somewhere else where it's not supposed to be. So putting people and not having right systems, it doesn't talk to what it needs to happen. We need to have people who are qualified to do their job. We need to put right system at the end of the day.
You see,
and the Ombuds report does underscore.
But you see, Vuyo, here's the issue. Where we go for our own healthcare, we have the right people running the system. And what drives that system is an act of parliament called the Medical Schemes Act. So let us not fool ourselves. This is not like education.
I don't think we can oversimplify our problems by purely making this.
No.
I think it's an oversimplification to say that
I'm not
the root of our problems is...
oversimplifying it. Okay. When you look at the per capita expenditure...
Hold your thoughts. I'm going to come to you just now.
When you look at the per capita expenditure on the medical schemes and on public health, we're spending 8 times more per person in that system. And that system is based on an act of parliament which predates, which comes from apartheid days. Okay, and I have no problem with people choosing to go private, but they cannot be enabled by an act of parliament to do that. Yep. You can't have a government that divides its society based on a law that comes from parliament into haves and have-nots.
Is that an oversimplification?
Look, I do think it's an oversimplification. Look, I'm not the greatest fan of the private health sector, right? I do think that we over-subsidize it and we shouldn't give medical scheme credits that indirectly subsidize the system. But I do think that to say that our problems lie in the fact that we have a parallel health system is an oversimplification. I think there's private healthcare all over the world now because healthcare is limited, right? Healthcare is scarce. Healthcare needs will always exceed available capacity. Right?
I think that is a point.
Just one moment,
yeah.
Good doctor. Right? Canada's got one of the most comprehensive public health systems, the United Kingdom as well. Right? And there are things that are excluded, and we're beginning to see, as people get wealthier, they're beginning to opt out or buying advanced access to healthcare through private healthcare, and it needs to be regulated. We had a health market inquiry that gave us a ton of different things that is wrong with our system. Gave some recommendations around what kind of regulations we can bring to minimize the impact of this inequality. And yesterday, I think some of the things that the doctor makes about handling overflows, all of those things cost money. You know, when you are, and you can't nationalize the private healthcare system because then you start messing with the right to property. When you start dealing with the right to property, you get the whole world upset. South Africa is a small little country in a big global system.
No.
Right? Hold on a second. So I think,
okay,
at the end of the day, what we have is that we need reform, right? No amount of pointing fingers to this side and this, that, and the other, and the political will that we need is reform. The National Health Insurance
people have been knocking on doors,
the National Health
raising their voices. Never being heard.
No, fair enough.
What do you mean when you say
when I say
reform? Who has to do what?
Well, at the end of the day, we as the people have to start to value healthcare. Okay. That's the first instance. The second thing is we need a system that speaks to our needs, right? So we need stronger primary healthcare, right? I think our healthcare system would improve vastly if in our 3,500 clinics we actually had a doctor on site, right? Because what the people want to see when they go into a clinic is a doctor. When they go to a hospital, sometimes they don't need to go to the hospital, but they go to the hospital because they see a doctor and they're going to get their medicines. Okay. If we can just hear where people are, make sure that they get the care that they need, it's a start in the right direction.
One second, you wanted to chip in. Sibongile, you wanted to chip in.
Yes, I do want to chip in. I want to agree with Russell to say what we need a reform system. We need a system that will cater for the people on the ground. Because, you know, the debate we are having here, yes, at this level, we understand it. But if you go to a person who's living in informal settlement, doesn't understand what we are talking about. All that person needs, it's just a basic healthcare services. When I'm sick, when I need to see a doctor, I need to see a doctor. When I need to get medication, I need to get medication. If I have to be referred to the hospital, I need to get there and get services. So what do we need as South African? It's our rights to be respected. We need to be treated as human beings, not as secondary human beings, because you cannot afford a private healthcare. So the inequality that is there on the ground, it shows how our system is. So what we need to fix is the things that are happening, the things that we are normalizing rising in the healthcare system. We are talking about the healthcare system doesn't have enough budget. But if I can tell you how many billions that we are returning to the Global Fund every year because the National Department of Health didn't perform its duties, if I can tell you how every time, if you look at the auditor's report, there are a lot of money that are not underused, or the money that have been returned to Treasury just because people who are sitting in these positions are not competent to do their job, and people who are suffering most are us on the ground. Absolutely. People who don't have medical aid, who cannot even afford to go to the nearest a private healthcare sector that is just around the corner. But then we are sitting here talking about all these fancy issues, but at the end of the day, what we need to think about and what we need the parliament to think about are those people who are on the ground, who are suffering most, because whether there is a strike, whether there is a corruption, whatever that happens in the country, it affects them mostly, not those 16% of the population that can afford. 84% of our population is the one that suffer most. So we cannot just generalize things. We need to think of those 84%.
You have to be specific.
Just a few things. One, I'm not disagreeing with Russell about the fact that the private sector is important. But where it exists, it's not driven by acts of parliament. It's people that opt out, and there's an augmented system that goes the same way as we do in education. There's no act of parliament that promotes that. The same way we do with our own security. We have private security. There's no act of parliament that says we can deduct this, and it's driven by an act of parliament. So I have lived all my life as a private practitioner in the private sector, and private provision will be here to stay, and you can make your choice. But you can't have a parliament that divides the society. Now, the second issue, I agree with the issue about the global funds going back. But do you know why the funds go back? When they give you money, it's because you've said you're going to do X, Y, and Z with them, and they hold you to that. When you can't spend it on X, Y, and Z, you give it back. One of the reasons why our system is not working is that there's no line budgeting. The CEO of Rahima Musa could not say, here's what I want. This to fix toilets, this for beds, this for equipment, this for human resources, and be given that money on line items, and it can't be deviated for other things. But they can't use it to get advisors, to get consultants. It's specific, or buy skinny jeans. It's line item budgeting. So the money goes back to those. I run an NGO funded by PEPFAR, so I know how strict they are. You can't take their money and go and buy luxury cars with it or use it for something else. And they are able to measure the performance of your system. Until we get to that, where Bara is able to say, we spent 5 billion, you were given 5 billion last year. Here, we are counting for every cent. We spent 8 billion. When you give them 4.5 the next year, what do you expect them to do?
They're going to suffer.
There are those issues that need to be addressed. And where power goes to go there. And if I'm given and I've budgeted, there's no room for me to have tenders for friends to say, hey, we want a fence. Then people form a company today, and suddenly they have the expertise to provide fences. The old system, when you have buying power, you are not a price taker, you are a price fixer.
Maker.
Right now, even in the US, Biden is telling the pharmaceutical companies, I'm capping your prices. You're asking for too much on Medicare. When the system worked here, the public healthcare system that was buying for everybody would not say, you are not private, you can't make money. But they'd say, you are not going to fleece us. We're not going to buy a bottle of water that you can buy on the street for 2 rands, for 10 rands from you.
Absolutely.
Rubbish, because I'm a bulk buyer. If it's 2 rands in the street and I'm buying for the nation, I'm going to buy it from you for 180.
So that's
there are those issues where the money gets blown out there and there's no money for workers. You can't be having the COVID people can't be incorporated. You got to go on strike for the people that were brought in to help with human resources during COVID. They can't be absorbed. Why not? They should have created permanent money to keep those people in, because they've seen that we are under-resourced in the public sector.
Yeah, but let's start figuring out what it is that we do. Okay. Right? So let's make those little low-hanging fruit investments. I think the first thing that we need to do as a health system in South Africa, we're never going to be able to meet everybody's needs, but let's make sure that we return dignity, right? Let's make sure that people that are sick, when they go into a clinic, they can see a doctor and they can get their medication. Let's get our hospitals empty so that they can focus on doing the work that they funded to do. Right? In most of our provinces, 60% of the people that come into outpatients department have no referral, are often just coming there for primary health care and to see a doctor. Right? Because when they go to the clinic, they can't get their medication. Right? Because the medication is out of stock. Over the last year, with Stop Stockouts, one of the projects that Sibongile's organization and ours work on together, in more than 50% of instances, in over 100 clinics, women couldn't get an injectable contraceptive, which was their choice. Which in any pharmacy you can walk in, you can get it. You pay 50 Rand or 200 Rand and you can get it. But for more than a year, across 8 provinces that we surveyed, people couldn't get the most basic thing. And I think we start building trust when we do that. Right? I think we need to also start talking to people directly. Stop treating people as outside of the health system. Every clinic should have a plan of engaging its community. Right? We have hospital boards and clinic committees that are made up of people who don't use the services in that clinic. Right? It makes them very far removed from overseeing something that they don't use. Right? And it comes back to Dr. Latapi's point. But let's make the community part of the solution rather than the subject of the solution. Now, and I think those are the kind of things that we can do. We can't fix everything all at once. But we need to start building trust. And building trust for me is really just about making sure that people can get the care that they need, that the ShopRite worker that has a job and goes to work 6 days a week but can't afford medical aid can still see a doctor when on his day off. That they don't go home sick or go to work sick because they can't afford to pay 400 Rand. Added to that, you know, there's inequality in our country. Not all doctors earn the same amount of money. Right? So there's a lot of underemployed doctors in the private sector. When you live in Randburg or in Sandton or wherever, there's a high concentration of medical aid. No doctor will see you for under 600 Rand. When you move south or west, you get to Roodepoort or you get to Soweto, we have private practitioners that are consulting for half of that. Right? So there's not an equal sense of income across the system. There are a lot of overpaid doctors and a lot of underemployed doctors. And the same thing within the public sector. There are also doctors who abuse the lack of management within the system, who exploit RWAPs or working outside of public practice, who come to work for half the day but bill for the whole day. You know, there's a lot, and that's also corruption. And the only way we can fix that is really by investing in the kind of systems that can hold everybody to account. And not wait for a crisis like this or a report like this. Just 2 years ago, the health ombud was at Tembisa Hospital that told us about that young man who was in the entertainment industry as well, a producer who died from hunger because somebody forgot to intubate him to feed. And he had lots to say about the management of Tembisa Hospital and how they failed. So these reports, tomorrow we're going to turn on and we're going to wait for a new report. We can't do this anymore. Right? We have to build trust.
There's something strongly I want to canvas you talking about reports. And that's before it was, I mean, we have many tweets that people are interacting with this conversation. But there's something I want to ask you, Mr. Bongile, based obviously on your previous engagement, premiers with MECs of health. Here was the response of the MEC this afternoon to the Ombuds report.
What did she say?
Hello.
I was hoping we could play, the MEC's response to the Ombuds report. But perhaps let's bring up some of the tweets that we do have from people who are watching, blessing. Saying it's very sad what is done by the ruling party to hire incompetent peeps clueless of their duties. Let's see if we can squeeze in a couple more. Des team saying, I recently experienced a small private clinic in PE called Meta Clinic, and the speed, technology, price, etc. was amazing. Check it out. I'll pay for the ticket. I mean, again, it brings,
I have absolutely no problem.
We have those clinics since Alexander.
Going out and paying for private care. I don't need to be assisted by a state that is invested in separateness. Because what is happening in healthcare makes a mockery of why we fought apartheid. Because there was separateness. whites were living there, and we had our small things there that were good for us as people that were lesser human beings. And we come here and we talk about the needs of other people. We need to ensure that when Gogo Dlamini is waiting at the clinic, Gogo Dlamini is assured that Dr. Letlape is also waiting in the clinic. That's the only way Gogo Dlamini is going to be assured of good quality healthcare.
Yeah.
Solidarity.
There's a doctor there.
Solidarity. Now, when I was young, medical aids were only for white people. There was no private health insurance, but there were private practitioners. I remember having severe tonsillitis and being taken by my parents to go and see Dr. Jivuo, who was in private practice, who treated me. I remember Dr. Jivuo treating my cousin, who died of leukemia in 1967. And that's why I became a doctor. So this notion that for private to thrive, you need a piece of apartheid legislation that creates distortions in society, that destroys prospects of solidarity, that creates haves and have-nots, is a folly.
So
the Medical Schemes Act is a crime against humanity.
Okay,
perpetrated by all of us, by all of us here,
yes,
because we're cheering for a piece of apartheid legislation that gives us preferential access to healthcare. Private provision is here to stay, and we should do it by choice, not aided by an archaic apartheid act that is now protected by supposed freedom
the Medical
fighters.
Schemes Amendment Act. Private healthcare financing is something that will always be here. I think the things that we agree on is that we have to find ways that we can act in a unified way. My colleagues and I wrote a piece at the beginning of COVID about a unified health system response rather than two separate parallel responses. Hold on, doctor. Which generated a lot of inequality of access, right? Yes, we can also, at the end of the day, we want peace, world peace. And how we get there, we all dream about it, people continue to dream about it, but the bottom line is we need to do the things that we can do, right? And as we improve the publicly funded healthcare system, less people will need to actually spend some of their hard-earned money on getting private medical aid, which many of them might never use, right? Or might never need to go to a hospital, right? I work in rural areas, so we drive out all the time. And one night, driving through the Northwest, I heard an ad on the radio sonder grense about what if you're in an accident, right? Where do you want to go, right? And that kind of fear that's generated amongst people where we're paying for medical insurance products, not just medical aid, right? For this fear that we don't want to end up in a public hospital. That needs to end. But I think to start, we need to improve primary healthcare. We need to build trust, right? And we need to get people to understand that this healthcare system is theirs. We need a healthcare system that speaks the language of the people that they serve. We need a healthcare system that is a citizen in the communities where they serve. And we need to progressively expand how people value health. Unfortunately, because healthcare is such a scarce commodity, most of our poor people, and I come from a very poor community in the northern areas of Port Elizabeth, we delay access to healthcare. Right now, 100,000 people died over 2 years from a curable disease in tuberculosis and continue to die, right? We have 8 million people living with HIV. Only 5.5 million of them are on treatment. We're 20% away from having epidemic control, but we get stuck, right? We have non-communicable diseases like diabetes. There's 4.5 million people living with diabetes. Only 1.2 million are in treatment. And where do those people access the healthcare system? At primary healthcare. And if we can say primary healthcare is not about doctors, but because of that inequality in access in South Africa, primary healthcare, people believe the NHI has arrived if there's a doctor in the clinic. And I think those are the kind of things that will build trust and start changing the shape of our healthcare system. But we can't just respond to, and I know this is a terrible report and this is a sad indictment on the government of Gauteng, but if we want to move forward, we have to start building trust. Okay. And I think Sibongile
Sibongile, quick last word for me.
Yeah, I think I will concur with Russell to say we need a primary healthcare that will respond to issues of the people on the ground, especially those who cannot afford. And those are the people that I represent all the time. And I think we need to start somewhere in order to get somewhere. And we need to start on the ground. We need to get communities, especially the poor, included in the decision making and understanding why they need to have a primary healthcare system that is working, why we need to have the healthcare system that is working. But also we need to address some of the issues that are still happening in the primary healthcare issues, like for instance, your attitude, the bad attitude, discrimination that is happening, that is coming out now and again. Honestly, as communities, we are tired of listening to these reports, but there is no action at the end of the day. What we need to do to see is action after the report. We had reports now and again, but there is no action after this report. And I think now it comes to a push where as communities we need to take it up to our hands. It took us as communities to fight to get ARVs. We need to fight also to access better healthcare services. So if we have to do that, I think we'll need to find a way of working towards that.
I thank all three of you for agreeing to come on a very healthy discussion.
The censorship.
Indeed. Thank you.
The censorship here is disagreement, doctors.
That brings us to the end.
And as long as we are truthful as South Africans, and there are lesser South Africans, if we talk about the private healthcare,
we've got to wrap, unfortunately. Brings us to the end of tonight's show. Obviously, I mean, so much to explore. Unfortunately, we don't have the time. Thank you for watching, but do join us again tomorrow evening for another conversation on these important national matters. Until then, have a good night.